Hello, everyone. Welcome to another webinar from the International Society for Telemedicine and Health. I'm Jefferson Fernandez. I'm a neurologist and Director of Education of our society. And in this webinar, we're going to have four excellent speakers that are from corporate members of our society. Very distinguished speakers with very important international organizations that provide services and care for people. Telemedicine, telehealth, transforming healthcare in the digital age is the main theme of our webinar. But before starting, I would like to introduce Dr. Michele Griffith. She is the president of the International Society for Telemedicine and Digital Health. And please, Michele, the screen is yours.
Thank you, Jefferson. Thank you so much. I'm just going to share my screen. Okay, so good day to everyone. Welcome. On behalf of the International Society for Telemedicine and eHealth, I'd like to welcome you all to a session that should be quite informative as we delve into the transformation of healthcare in the digital age. As we are in the midst of the digitalization of healthcare, the ISfTEH has become a global resource for those who are interested in improving access to care and improving health outcomes. The society has actually been around, founded in 1997 in Basel, Switzerland, with the mission of facilitating the international dissemination of knowledge and experience in telemedicine and giving access to global experts worldwide. Our mission over the decades has not changed. We have expanded into over 100 countries and territories and really have become a federation of national associations, corporations, academic institutions. Also, under our umbrella, we have individual membership, nurses, students. Our role as we embark upon expanding access to healthcare via digital health involves offering a number of specific services. We have, over the decades, actually we're in year 28, sponsored an international conference in many different countries around the world, which allows for significant and impactful networking. We have a very robust educational program, which encompasses webinars like the one today. We have working groups where members who have similar interests can collaborate on events, on research articles and white papers. We have proprietary educational activities, including a course series that is soon to launch. And we even have endorsements of educational programs. Additionally, as you can see, and you will hear from some of those corporate members today, we provide services in accreditation, consultations on regulation and policy. And as I would like to keep it very brief, if you'd like to learn more about the society, please feel free to go to our website. We're actually in the midst of launching a new website, but you can still go to this particular link and learn more information. So thank you, and looking forward to a very informative session.
Thank you very much, Michele, for your welcome message. I'm going to just tell the name of all of four speakers, and then we start soon after that. So we're going to have with us today Dr. Milton Chen, he's CEO of VSee. Riley Normandin is Director of International Growth of AMD Global Telemedicine. Dr. Chen Griffith, President and CEO of URAC. And Dr. Waqas Ahmed, Founder and CEO of American Telephysicians. So it's a great pleasure to have all of these excellent speakers that have accepted our invitation. And please, gentlemen, when you start speaking, if you like to add something else about your profession or your company, please feel free to do it. So it's my pleasure to invite our first speaker, Dr. Milton Chen from VSee. His talk will be about a no-code, low-code building block approach to expanding EMR capabilities. Milton, please, the screen is yours.
Thank you so much for the honor of speaking here. I really, really appreciate it. I'm grateful for the opportunity. Um, I check, you guys see the slides?
Yeah, perfect.
Okay, great. Thank you so much. So, we live in a very digital, more and more digital healthcare system. Everything's anchored on the EMR. Often the EMR of your hospital or healthcare system really dictate everything you do. So we've been spending the last 10 years to really think about when you start with the EHR, how do you seamlessly expand the EMR capabilities so you could have achieved everything you need to do in digital health. And the key approach we take is a no-code, low-code approach. And I'll explain in a moment what that means there. So our company background is that we actually were started doing telehealth work roughly about 20 years ago this month. In fact, our very first project in our company life is actually doing emergency response in Hawaii. You see there how to create these sort of connect to from the airplane to boats to create extremely challenging scenarios. And now with the VSee capability, as you can do these remote physical exam, connect medical devices, put it into medical kits and so on, as well as you can do things like remote patient monitoring. Again, one of the themes is how do you start with the EHR and extend it with remote physical exam, remote patient monitoring, all in a single tool set for your EHR. Again, another thing we have done a lot of work is around telesurgery. So the idea is how do you even adding these really extreme complex high performance workflows into your workflow. So one of the motivating ideas behind us is right. So I'm pretty sure the audience, you guys have all these great ideas you want to do in digital health. Against you, typically you have to build on top of your EHR. Now the idea is what happens when you have your ideas. Typically, you have to hire some engineers, you hire some designers, and often what happens is you build your prototype, and then when you try to launch your production workflow, you get sort of stuck in this because often it becomes extremely expensive when you move from the pilot to these sort of production workflows. And one of the reasons it becomes really expensive is the life cycle cost. It becomes really expensive, right? You hire some engineers. As soon as you have a successful deployment, let's say 2 years later, that engineer might have left already. Now what do you do? Like just again, maintaining the software become extremely, extremely expensive. And in healthcare, people typically think is, can I buy a solution? Can I build a solution? Unfortunately, both solutions are terrible because whatever you can buy, it probably doesn't do exactly what you need to do. And the remaining delta workflow will make it really expensive to the practice of telemedicine. And if you try to build a managing software team, maintain it, become almost impossible in this. So then our approach is to say, what if instead of just say either you buy a software or build a software, you start out by providing a set of Lego like building blocks in there. So the idea you have your EHR, you're building your connectivity on top of it using HL7, FHIR, open standard interfaces, as well as these were proprietary APIs from the EMR companies. And then on top of it, you create a set of these Lego like building block where everything has APIs. And the reason we said the no code, low code, right? I'll draw a silly analogy. So 10 years ago, you want to create a web page. You probably needed some programmers, but today you don't need any programmers to create any beautiful functional web page. So we take that same approach using no coding. That means you as a clinician, you don't need to have any programming experience. You can just use our building block and create these really complex workflows. And then low code means there are times you need to create, let's say, a mobile app, some complex workflow. But again, using their APIs, you can typically achieve about 10x reduction in time, the cost, and so on. Again, the whole idea is now you, as a clinician, Instead of waiting for IT to do things for you, you should be empowered to do whatever you want in this. And one of the beauty of using the no-code, low-code approach is you get these analytics right out of bat. So this is a screenshot. So you can click on things like add widget, just creating sort of whatever analytics you want to. Again, now this could tie into using no-code and low-code to quickly adjust the workflows. Again, the whole idea is it's not like you build a software, you deploy, but in this case, the system is live and dynamic constantly in this. And I'll just give you a kind of a complex workflow you can achieve using these approach. This is our project working with UNICEF's Philippine Child Protection Units. So the idea you can create this emergency dispatch. And one of the system is they have to operate in places that has no internet. And how do you work? We create an online, offline form version where you can do this data collection when there's no internet at all. As soon as you get to a place that has internet, you automatically synchronize with your EHR, but all the workflow is under your control. And this is a project with the Save the Children. Again, you can bring these from indoor pollution monitor, pair with the medical records from the EMR, and blend it into these complex workflows. And this is a project where one of the things when people think about telehealth is what I would recommend is imagine not just doing video conference, remote exam, how do you actually create actually high impact clinical workflows? This example where our baby's first 1,000-day project, where you could actually blend in a bunch of these capabilities, and result is you empower the clinicians, whether it's a nurse, medical assistant in the front lines with physician, again, using this building block to create really, really complex workflow, again, without getting programmers deeply involved in this. And the final thing I'll share with you is often digital health, they get stuck in pilots, I was mentioned, because when you go from pilot to production release, the costs often become extremely expensive in this. So the idea is you have to make things really, really easy for people to change their mind in this. So in conclusion in this, so often people think about is between technology versus features in this, I would recommend is really focus on adoption. Is whatever ideas you have, if you cannot make adjustments, often you get trapped in this. Again, empower people to make these adjustments in this and focus on that, not just what does it take to launch your project, assuming you have a very successful project, what is the actual total life cycle costs of your effort to help? And that must vastly exceed the value that created. And finally is between technology and tool, in VSee, we like to ban the word technology. We hate technology. The reason is I don't think anyone wake in the morning and thinks, I need more technology disrupting my life, all these things. It really must be what tool can you create to add value? And another word we actually ban at VSee is the word solution. Solution tend to have this like, oh, I got a solution for you. No, at most, you give people option. They may choose your option, they might choose something else, but having this option idea, now the idea you give them is like you give them building block, give them options, give them tools, and now they can actually do whatever they need. Again, leverage the EHR to do all the things that telehealth can achieve for them. Yeah. Thank you so much.
Thank you very much, Milton, for this very interesting experience from VSee. Really things that make us to think about the approach that we can have. Wonderful. So we are going to our next, before going to our next speaker, I would like just to remind you that you can post your question in the Q&A icon. So please do ask whatever you want to do and take the opportunity to exchange experience with these wonderful speakers. So the next one is going to be Riley Normandin, Director of International Growth from AMD. The topic he's going to approach is how to integrate new telehealth technology with existing systems for optimal workflows. Okay, Riley, please, the microphone and the screen are yours.
There we go. Thank you for that. Thank you for the opportunity. Riley Normandin, the Director of International Growth for AMD Global Telemedicine. And What I'm going to talk about for the next few minutes is how to not only integrate new telehealth technology into EHRs and health systems, but how to do it in a sustainable and successful way, so that you're able to implement and continue to sustain for many years a successful program. There we go. So to start, defining integration now, because there are so many different, much like the terms telemedicine and telehealth, those terms have become very very open, and integration, I think, is the same way. So defining what is being integrated, I think, is a good starting point. So for one, is it third-party video conferencing capabilities into an EHR? Is it medical device data from rural clinics or your point of care stations to expand the reach but also improve documentation? Is it consumer apps and patient engagement tools for helping schedule appointments and empowering patients with, again, appointments, portals, etc.? So determining what is being integrated is a good starting point, because what you don't want to do is, and I'm sorry, I should take a step back here. The way AMD defines integration personally is with the device data. So our solution or option, as Milton put it, is having an aggregation for directly to an EHR, and it's a tool to see more patients and better document some of those solutions. So regardless of where the care location is, whether it's in a clinic, in a hospital, doing rounding for vitals, being able to streamline some of those processes where the data is being collected, and doing it in a way that's sustainable for the users, the nurses, the clinicians, etc. It's not only better documentation, but it allows a lot of wasted time to be avoided. So we do this by first identify the goals of what that integration is, right? Don't integrate in a silo where it's not. There's so many different technology options and products in the market today. It's not just what can we integrate and how. It's more, how can we integrate this technology in a way that makes sense for the health system? We've learned from some early integrations that it was an integration for vitals and data that was done in a way that was more technical than clinical. So being able to improve some of those, learn from mistakes, do it in a way that makes sense for everybody is critical to any long-term success. There isn't tremendous value in integration if the process to get that data where it needs to be is cumbersome and requires more mouse clicks than necessary, and becomes a burden for all the users or the members of the health system that need to be a part of that. Is it being done to streamline and get eyes on maybe some satellite clinics that not under the purview of the hospital? That is also an important thing to define. What are the pain points for the current health system and how those can be improved? Because doing it in a way that mirrors existing clinical workflows. And this is the big one, it's consistency in the process. So first and foremost, doctors and clinicians, they don't want more technology, they want less. So being able to make their lives easier should really be the first step when defining and designing an integration. So don't ask them to change the way that they're providing medicine necessarily, but can we do it in a more efficient way without making your life more difficult? And some of the steps to avoid making life more difficult for everyone involved is don't layer technology. You don't want to layer on top of a layer. What I mean by that, it could be, hey, asking the IT team to integrate a third-party application. Make sure that that third-party application maybe authenticates the same way that your current health record system does. So you don't have to manage two different databases of usernames and passwords, etc. Make sure their permissions mirror your EHR, or if it's patient databases for health records or calendars, having to manage and service two separate applications, one for your day-to-day in-person healthcare and one for telemedicine, doesn't make life easier. Makes life more difficult to coordinate and manage those things. So it also will utilization of said platform for those staff that you rely on, to such as the nurses and the clinicians. If it's difficult, utilization is not going to be where you want it to be. It's not going to grow. So consistency is in the process is key. That goes with telemedicine programs in general, in my opinion, but also when it comes to integration, being able to make sure it's sustainable. So avoid duplicate redundant tasks, right? So avoid multiple mouse clicks, reducing manual entry of certain things. So being able to, with the mouse click, streamline that into the EHR, and utilize open integration protocols when possible. FHIR, HL7, some standard API calls, things like that, where you're not necessarily tied down to a single technology provider. So being able to hold them accountable if you find something that can improve you, and you're using proprietary integration methods. Getting yourself out of that can be more difficult. If you're using universal integration protocols, it makes life easier and empowers the health system as well. And of course, making the process repeatable for the staff. That's the big one. You don't want a burden on the doctors or the IT. Syncing of appointments for your doctors. Again, multiple calendars for telemedicine and in person. You want to make sure those are syncing together so that everything is firing on all cylinders, if you will. We've seen programs that have one calendar for the telemedicine appointments and another for in-person for the same doctors, and it's a nightmare, right? So being able to mirror in-person clinical workflows is the key to any successful long-term integration. And that is the end. Thank you for your time.
Thank you, Riley, for your insights, for your experience as well. Just as we are getting more and more participants in our webinar, quite a high number, some of you that might have joined a bit later from the beginning, we are in the Telemedicine and Telehealth webinar, Transforming Healthcare in the Digital Health Age, from the International Society for Telemedicine and Health. And here we have spectacular speakers that are from companies that are organizations very important in the global approach of telehealth, telemedicine, and digital health. Please, you can forward your questions in the Q&A icon. So our next speaker, and it's my pleasure to invite Dr. Sean Griffith, President and CEO of URAC. Please, Sean, the screen is yours.
Jefferson, thank you so much. Can you see my screen okay, Jefferson?
Yeah, that's fine.
Okay. Well, good morning, everybody, or good afternoon, or good evening, I suppose. This is a worldwide audience, so I want to thank all of you for taking time out of your days to join us. I am the president and CEO of an organization called URAC, located in Washington, D.C. That's D.C. out my back window. And I really want to talk about the quality aspects of telehealth. And we're facing... when it comes to telemedicine, we saw this surge during the pandemic, and now we're seeing sort of this settle back down. And there is a lot of concern, especially in the US market, about good telemedicine versus bad telemedicine, and what distinguishes the good from the bad, and how can you tell? Basically, telemedicine has lowered the barrier to connect with a patient. There's a lot of technologies that are out there, and now that anybody can come to your front door and offer you telemedicine, how do you know who to trust? And that's really sort of what I'm going to talk about today. So URAC, you may not have heard of URAC. URAC is an organization that's been around since 1990. We're nonprofit, we're independent. Our whole job is to validate quality within the healthcare landscape. So we are trusted by states in the US, by the federal government in the United States, other countries around the world, to where we come in and we are like an auditor. We come in, we're independent, we take a look behind the scenes, we make sure that everything looks like it's being done in a trustworthy manner with evidence-based medicine. And one of the special things about us as an organization is that we don't sell any consulting services. We think that selling consulting services to an organization that's going through an accreditation is a conflict of interest. So we don't do any of that. So we are independent auditors of what is quality in healthcare. One of the things that I've talked about in telemedicine is bad medicine in telemedicine is just not worth it. Bad medicine on a good camera is still bad medicine. So some of our digital health clients, we've been doing telemedicine since back around 2016. We have been involved in setting the first real telehealth standards in the United States. These are some of the organizations that we've been honored to work with, some here in the US, some international. I say that it's remarkable that from here in Washington, D.C., we accredit organizations in Cairo, Egypt, and in Brazil, but also all across the United States. And part of the reason why we do that is because we're trusted. We've earned our right to talk about what is healthcare quality. And we're honored to work with these organizations, and we're honored that they have earned our accreditation. So there's a couple of programs we offer, and I just want to tell you about those. People will tell you I'm not the best salesman in the world, and that's because I'm a physician, and I really care about the quality. That's my main focus. The programs that we offer a telehealth accreditation. That is for organizations that directly provide care. We've been doing that for coming up on a decade now. We also do remote patient monitoring. There are organizations who that is their focus of telemedicine. During the pandemic, we also started offering something called telehealth support services certification. And what was going on is we were looking at telehealth accreditors, and we had organizations who wanted to go through our accreditation to demonstrate their quality. And they said, well, who can we work with? Who are the platforms that we can work with? And that's where the telehealth support services certification really came from. That's sort of the behind the scenes group. So if you don't have clinicians actually delivering the care, you'd be the certification. If you do have the clinicians, you're the full telehealth accreditation. The remote patient monitoring, we say that is a growing component as for providing care digitally, and that's why we offer that also. What's the relationship between regulation and accreditation? If you think about the two, when I was practicing as a physician, I was licensed by the state, but I was also board certified by a national body. And we say that regulation very often sets the bar for safety. When I was licensed to practice, I was licensed in the state of Missouri. I was a physician licensed in the state. That didn't mean as a rural family physician that I should be doing heart transplants. I hadn't been trained for that. Now, technically, as a licensed physician, I could provide that, but I wasn't trained for it. So it was the accreditation that sets that higher bar, that higher standard. So why does accreditation work? Why does anybody do accreditation, whether it be for hospitals, whether it be for clinics, whether it be board certification for physicians? That's really based on best practices as reviewed by experts. If you're going to go through accreditation, if you're going to be doing accreditation, what is actually involved in that? The other things that come into accreditation is data protection. We've had the recent Change healthcare problem here in the United States where organizations were having difficulty accessing their data. We've had some ransomware attacks. How do you know that your information is going to somebody that you can trust? We check that. How do you know that the medicine that's being practiced is evidence-based and has clinical oversight? We check that. And because we've been doing this for so long, we have states, we have federal organizations who say, if URAC has checked behind the scenes, we trust that. And that's really important when it comes to healthcare, because you can have somebody who looks great on camera and who does a really nice job of talking to you, but if they're not doing things in the right way, you've let a bad person into your house. You're opening yourself up for problems. Just last week, we've had this big news about telefraud, where there was an organization that was basically using telemedicine to deliver medications that they shouldn't have been doing and not following clinical guidelines. Those are the bad stories that hurt the good providers. And we really think that accreditation and the work that we do helps to highlight the good guys. Things that are important in telehealth. First of all, you want to make sure that you don't have security issues. An EHR is great, but it needs to be secure. Texting is great, but it needs to be secure. How does all of that work? How is it integrated? As we heard from a previous speaker, you're not going to get the providers to provide telehealth services if they have to go do something completely different when it comes to telehealth, whether it be their scheduling or their platform. It needs to be integrated. I was a chief medical information officer, and I can tell you, if you don't put it in the provider's workflow, it's not going to get done. Also, how do you make it reliable? How do I make it so I just can't reach you from 9 to 5, or I just can't reach you on Thursdays, but how do I make it so that it can be a reliable part of the care and be complementary to the care when appropriate? There are some things that are fantastic for telemedicine. We're seeing this boom in children's healthcare, this boom in behavioral healthcare. Those are fantastic, but how is it complementary and not considered to be a replacement for everything? I'm still not quite at the place where I'm ready for a kidney transplant over 5G cellular. I just don't think that we're there, and we need to make sure that we're talking about good care. How do we use it to improve access and to improve health equity? That's a big concern in the US, where we have provider shortages, where we have provider maldistribution, where they're not where they're needed. And how do we make sure that this actually is a focus of organizations to make sure that we're adding more doors for the population to reach us? How do we have a curriculum for the providers? If you've ever seen somebody who's bad at telemedicine, it's terrible. I mean, they just don't know what they're doing. They don't know how to maintain eye contact. They don't know how to connect. How do you train your providers to be good at it? I can tell you that medical students, the first day you hand them a stethoscope, they're not really good at it. They're pretty clumsy. How do you make sure they're not the same when it comes to a camera or to a telehealth visit? And how do you include telehealth so that it's integrated in case of a disaster? In case a hurricane comes into the Gulf Coast, in case a tsunami hits, in case a typhoon hits, how do you make sure that telehealth can help to keep your doors open when your doors have been blown away? And how do you provide that care for your community in those desperate times? I wanted to have an example here of some of the telehealth providers that we work with. We work with correctional health, care in prisons. We work with diabetic health, Glue Care, a diabetes care group, mental health and substance use disorder, pediatrics, geriatrics. We're honored to work with Anshams University in Cairo, Egypt on their stroke care, and as they work to become a telehealth hub in Africa. AR Care, federally qualified health centers in the United States, serve people who have access issues, and they're using telehealth to provide behavioral health care into schools. I think those are some of the examples how telehealth is this incredible tool, and we give it and when we share it with really intelligent, thoughtful organizations, they use it to serve their communities in fantastic ways. And if you're not making sure that quality is a key component of every single telehealth interaction that you have, then we face the risk that people are going to say the bad is more than the good, and they're going to limit telehealth. And we have opportunities now to prove that it's worth it and that it's a good thing and it can be a core component to quality healthcare. We're honored to work with organizations across the world, honored to be on this webinar today. You know, our information is on our website. We really are committed to independent quality verification so that telehealth continues to grow and continues to be the thing that everybody wants it to be. So thank you very much, Jefferson, and I'll turn it back over to you.
Thank you very much, Sean, for bringing up all these important points regarding quality of telehealth and telemedicine services. Wonderful. So reminding you again, please forward your questions to Q&A. Then after our last speakers, we are going to have the Q&A session. So it's my pleasure also to invite Waqas Ahmed, founder and CEO of American Telephysicians, and his approach will be, what is not telemedicine? Please, Waqas, screen is yours.
Thank you so much. Good morning, good afternoon, good evening. It's always very heartwarming to be part of this broader group. By introduction, my name is Dr. Waqas Ahmed. I am a physician based in Florida, a kidney specialist by profession, and I'm the founder and CEO of the company American Telephysician, a physician-led virtual healthcare company with operations both in the US and international market. It was great to, have here, expert talks with Dr. Griffith and, Dr. Griffin, as well as, Milton Chen. I've known him for quite some time, as well as Normandin. I think one thing was pretty commonly a misperception, because when I travel internationally to a lot of countries, because not every country has a same digital infrastructure. A lot of countries do not have actually EMR system to begin with. The definition of telemedicine is different for them versus the definition of telemedicine in the US. Over the last, obviously, since ever the COVID came, we have seen how, the evolution of telemedicine has happened. And one of the big, challenges has come, what exactly is telemedicine? I always thought, rather than saying what is telemedicine, let's talk what is not telemedicine, because I think a lot of the old conception is still focused on that. Is it just a video consultation? Because this is how telemedicine started, just access to the doctors online. Certainly that, did solve some of the problems where, that patients can get a convenient consultation at home, but there was so much gaps. And if you look at the actual traditional healthcare problems, we have what I call the 3A problems of our healthcare system. One is the access, the other is affordability, and the third is awareness, patient education. And all of these actually lead to our hospital-centric delivery model. Patients, keep getting hospital readmissions and all those things there. So the big problem has been the lack of continuation of care. Telemedicine as a virtual consultation did solve some of the problem with the access, especially access to, but it has not so far addressed other challenges. As
Waqas,
yes.
Do you mind to put in full mode your
sure.
presentation?
Yes, absolutely. Okay. Can you see now?
Yes, that's great.
Okay.
Thank you.
All right. Thanks for pointing that out there. So one of the big challenge, I think, as rightly mentioned, there's a lot of telemedicine solution. There are a lot of what I always call that we have moved from a paper mess to digital mess, unfortunately. And that has caused most problems, because then, it has so many examples to share. I see patients in the senior living facilities in Florida for nephrology. These patients come from the hospitals, different hospitals, no integration in the US, still in the EHR system. Getting that access to that data has been very challenging. So, and especially if you're trying to see those patients remotely, it's even more difficult, because as a physician, we all know that, it's not just like seeing the patient. It's like, unless I have access to that medical data, what happened, what are the labs, so you'd certainly need to have access to their previous medical record information. to kind of at least make a decision about the future treatment. And what happens after you have seen the patient? Because you have no idea, then you are remotely, patients are remotely distant from you, and where the patient is going to get the blood work, where the patient is going to get all this in there. So this is where I think the fragmented model is currently needs to be solved. Another big issue, which is also, I think, needs to be addressed, is that rather than just focusing on the disease management, where I'd see the telemedicine as a big role, is essentially the risk assessment as well as prevention and wellness, because that's where the population health management is. So if you look overall, how the market has changed, I mean, obviously we all see those healthcare, outside healthcare, we see the Amazon, we see the other marketplaces, we see different, where patients are, getting all the services at home without leaving them, the delivery. But when it comes to healthcare delivery at home, that's where there are a lot of those challenges because it's not as simple. And secondly, the healthcare system's adoption has been poor. And when you talk about international countries, a lot of those, developing countries, they're even more worse because they did not have exactly a digital infrastructure to begin with. Solution is certainly, the smart, what we call a smart virtual care. I think this is what the actual telemedicine is supposed to be. And it is that wherever the patient is, they are able to get, not only access to the physicians, but also access to other integrated healthcare services, because they are able to be monitored, and they are able to be, have access to all the other services together. And that is, I think, the foundation of the virtual healthcare. And so that how is possible? You obviously need to have a deep integrated technology system to integrate, all these services at one platform, or at least interconnected solution. And then you can have continuation of care, whether the patient is at home or so. Sounds pretty dream, right? That how it's with them. So I'm going to show you some case studies. This is how we have been, delivering the care for our patient and how we started our journey. As a company, Microtel Physician, we have three integrated pillars, I would say. One is our technology, which is like smart clinic. Like I'll give more synopsis of that. And second, we build a virtual physician network in the US and in international markets for second opinion services. And third is like how to have a true integrated partnerships, right partnership for the right care. For example, if you are talking about cardiology care, you need partnership with echocardiogram company or companies who do stress tests. I'm a nephrologist, patient on dialysis. Obviously, it means if we want to build a kidney care ecosystem, we need to actually integrate with dialysis companies or, those diagnostic companies which are in that space. And utilizing this model, we have done quite a few projects in the US with the government and the healthcare systems, as well as this is, I would say, what you call how the blueprint looks like. That customized technology for based on their clinical settings, as well as based on the specialty. And then you bring those relevant physicians and the providers, NC survey providers, and do the right partnerships. The number one, then there are, on the technology side, you got to have, these are the steps we need to have: a data integration first, risk, and then that will allow you to do the risk screening. Then you do an online consultation, then allow to have a personalized care plans, remote patient monitoring, and triage, and do the outcome. So we built and we continue to evolve our system, which is an integrated module, a cloud-based solution, customizable for various markets. We have clients international market as well as in the US, where we customize solution. If you already have an EHR system, then obviously that can be integrated. If you don't have EHR system, this has a built-in EHR system for that, and we customize it for that market. And then obviously all the other module, remote patient monitoring, risk assessment, and so there. And the key part is also not only a lot of EHR system, mainly a focus on the provider side, The key part is also giving access to the patient side so they can have access to all the other services I mentioned, labs, radiology, scheduling of those others. Healthcare services is the fundamental key. So those results can essentially, come back. Some of the screenshots, like how we do the risk stratification, we pull the data from other systems, and then all the data is coming from the devices as well. So it's, and then we have those algorithms and formulas showing your risk for different cardiac and stroke risk and, the chronic kidney disease, or actually now with mental health also. Once you know which patients are high risk, those obviously can be enrolled into remote patient monitoring, and then have a customized care plans. Imagine you're an endocrinologist, you're able to manage those patients from anywhere as long as you have access to their blood glucose reading from home. This is how the true utilization RPM. But the other thing is we have to have now, everyone hears about AI. That's where to decrease the burden, because one of the challenges for telemedicine, which we have seen, physician shortage is still the case. No matter like you're seeing a psychiatrist by telemedicine, there are a limited number of physicians or specialists. The idea is that to how utilize technology to do the triage, that which patients really need to be seen and which are the other one which can be essentially managed and monitored with just supervision. Not every patient needs to be seen. Unfortunately, that is the case with our current payment method, that fee for service, but everything is moving for value-based care, and this is where this clinical pathway. So this is example how our system works. Like you're getting the straight data from your EHRs or your devices. And then you have two pathways. One is the clinical pathways where you're essentially triaging patient. Only those patients who really need to be seen are essentially, scheduled with appointments. And then those who essentially just need monitoring and wellness, that's where AI deployment is going to be huge. Of course, there are AI applications on the clinical physician side also, but I see a true value of AI into this. So building these, we have built a couple of specialty care programs. We're obviously expanding into others. Some of the examples is in our NeuroX, which is our brain health vertical. We providing service to hospitals and so on. And recently, we have won the contract with this, for the CMS for dementia care, and certainly, this is where the whole value-based care. In the US, we have this marketplace, what I was talking about, giving access to patients, one-stop access to all the services they need. They need labs, radiology, online doctors, so they don't have to go, outside, anywhere else. It's just like the integrated, and we're partnering with other healthcare service providers to get listed. And of course, we're working, and then there are different other ecosystems which we essentially partner with. This is one we partner with University of North Florida to build this personal health monitoring, athletes monitoring and wellness and so on there. So the idea of what truly telemedicine, I think, is integrated virtual and smart connected ecosystem. So the data is integrated, and then of course you are providing the right care at the right time with the right provider and at the right cost. Thank you so much for your time. And of course, I think demonstrable outcomes are pretty important.
Thank you very much, Waqas, for your approach, for showing us the approach and solutions of American telephysicians. So now we are going to the Q&A session, but before that, I would like to invite all participants here that are not already members of the International Society for Telemedicine and Health to join us. In the chat box, there is the link. Frederick was kindly presented there. So you have the opportunity of having not only this type of webinars, but also other activities from our society. Check our website and join us. So we have a lot of questions. We have 10 minutes for them, probably not be able to answer all of them, but I'll start with the first questions that arrived here. Actually, there's first a comment from Bernd Blobel. integration and interoperability must go beyond the data focus. I'll take the opportunity of this comment to ask you, Riley, what was the main, if you can mention one or two main hurdles and that you have in this interoperability approach to be able to do the integration, and how did you think it's possible to overcome it? So you can choose one or two experience that you already have had.
Sure. Yeah. So one of the challenges, when you think about a telemedicine satellite clinic that may have a number of devices, vital signs, EKGs, spirometry, imaging, etc. Depending on how you integrate that to an EHR, that could be 4, 5, 6, 7 different integration points, right? Where if you're integrating each of those devices separately, that you then have to maintain and service. Our approach has been, because our software is an aggregator, if you will, where we become the integration point for all of the devices, and then there's one integration point between us and the EHR. So that makes it easier to maintain for both us and the health system in general. So being able to limit the points of failure to the EHR has been a method that has been successful for us.
Okay, thank you very much, Riley. Then I put together two questions that are directed to Milton Chen. So Suleiman asked, thank you for your presentation. Your experience, in our experience, what is the main reason for, or in your experience, what is the main reason for integrating Lecky into more EMR? And the second question comes from Turagadi. I have a question around integrating telemedicine into existing EMR systems with local servers. How best it can be done? Milton.
Thank you so much for the questions. The first one, the reason you want to interface into EHR is if you look at the entire healthcare system, right, EMR is really the anchor of how hospital physicians work in this, right? So if you're not integrated into EHR, you create a lot of friction, right? Then physicians switching between different. That I think it's a no-go. Maybe during the COVID, a bunch of people hop on this thing, but I think in the future it has to be seamlessly integrated. Otherwise, I don't think you can get any patient or clinician adoption in this. Yeah. So again, I think we believe that. So in terms of how to do it, the good news is if you look at the open standard from HL7, FHIR, it has become fairly mature in this, right? Pretty much all the EMR companies support these open standards. I would just say is don't try to be creative. Just follow the open standard and do what the industry practice does. And then I think you'll achieve success.
Thank you very much, Milton. Next question will be to Sean. Okay, Lloyd Williams from Carefluence. And the question is specific to Smart on Fire. How many of you have seen a graduation to this strategy vis-a-vis the traditional approach? Something we started doing back in 2018 itself for telehealth smart integration with EHRs. Also on expansion of EHR capabilities. How many of you are leveraging open EHR standards? And so the question is open to others. And the question is also for Milton. He asks, what is URAC's thought on this? We can start with you, Sean.
Jefferson, thank you very much. So there's a couple things. One of the things that we do at URAC is we work with established organizations that have been delivering healthcare for decades. And for them, very often what you see is they will start off with their own sort of homegrown little special area where they do some telemedicine. Usually they have a physician champion, which is key for the adoption within a larger organization. When we think about the EHR, the things that we talk about is we don't say a particular EHR, we don't say a particular platform. We talk about, it needs to be integrated. It needs to be proper oversight, proper data security. So since we work with established organizations who use traditional platforms, the Epics, the Oracles here in the market, the Meditechs, whatever you want to talk about, generally they've grown over the past few years now to where it's integrated within that EMR platform many times. We also work with innovative companies. We work with some companies who started up their own little platforms and they've grown from there. So we don't take a stance on what the tools are exactly you have to be using. We say that the tools have to be integrated. They have to have the patient in control of their data. They have to be secure, those sort of things. Now, as an old chief medical information officer, I can tell you that if it's not part of the workflow, no one's going to be doing it. But we work with organizations where the physicians do telemedicine all day long. And for them, the telemedicine is the platform. We have others where they move back and forth between seeing patients in a clinic to doing telemedicine visits and those things. And so we don't have any technology requirements. We don't have an endorsed platform. We just say that whatever platform you're using has to be good for the patients, good for the providers, and secure. And that's really sort of the focus from our standpoint. I'm all for standards. I'm all for platforms. I'm all for an integrated workflow is really the main adoption solution these days.
Okay, thank you. Is somebody else willing to comment on this? Okay, so we can move.
Something.
Yes, sorry, please, Milton, sorry.
Susan, yeah, I would say it's just like, for us, people like us, we're building on top of EHR. On the opposite side, if you look at the whole EHR movement, right, there's massive development from the Epic, Cerner/Oracles, and so on. In fact, if I were to use Oracle as an example, right, they're extremely ambitious, right? They're rewriting all the Cerner, they do the massive, rewrite. So that can make our job much easier because the richness of the ideas is these open APIs out there, they're always a little bit behind on what the good solution, good integration needs to do. So by having these vendor like Epic, Cerner, all these, right, having this nice API, again, so things that make our life so much easier. So I'm pretty excited about, I think what will come on the pipeline in the next couple of years, have a really seamless, amazing integrated experience.
Thank you, Milton. Waqas, I have a question for you. You presented several approaches, and I was curious, how do we approach the education of physicians in telemedicine, telehealth, and the use of the different solutions that are available for the patient's care?
So thank you. I think the same approach with once we got to know the existing infrastructure first and what are the capabilities are, and then I think the physician involvement in education is the fundamental key, because this is what we saw in the COVID, and also any not only just telemedicine, but also any digital adoption, whether it's an EHR adoption or any other international market. So understanding their problem and because they are the one who will be driving force to have the adoption for their patients and engagement and so on there. So I think the fundamental part I think the idea would be to, when we're developing those clinical workflows, it got to be in collaboration with the physician, because I always say, I may be biased being a physician, and I think, the company's approach, but I've seen that physicians being the best architect of designing the solution, because they know the clinical workflows, and since they are the one who essentially use the most, I think their input is important. A lot of time we've seen the solution which are essentially built, and then they try to train the physician. That approach, always see more resistance rather than the other way.
Thank you very much, Waqas. So we have time just for one last question. And please, this question is an open one, so any of you or all of you could answer. It's from Prax. And the question is, how are you using telehealth to impact clinical efficiencies and ultimately influence behavioral change? In order to widen access to care, care needs to be affordable. Please, any of you could start?
Well, I'll go ahead. Hi, it's Sean Griffin. What we're doing when we work with providers, we're actually seeing organizations that have really leaned into the affordability prospect of this, where they're not just access, not just equity, but the affordability, to where you're seeing federally qualified health centers, which generally serve low-income people, using this to extend access into schools. AR Care is one of the ones that I mentioned. You also have the ones where it's not about affordability, where it's all about convenience and people who will pay for that convenience. But when we work with organizations like Texas Tech, where they're serving the prison population, it's about the cost of the delivery of care and the safety of their providers. So I think that different strategies come at this in different ways, but I agree that affordability has to be a component for anything consumer facing. In the United States, affordability is more of a question for the payers to be bringing up, and they want to save money by using telehealth. It's just a lot of the models that are out there are not driving to save money. They want pay parity for telehealth access.
Thank you, Sean. Anybody else would like to make a comment?
Yeah, I would say so. I personally traveled to over about 50 countries doing in-field telemedicine deployment. And I took multiple trips to Iraq, Syria, probably 20 plus trips to Africa, and so on. So I think if you look at the global scale in this, right, it's like no telehealth in many places equal no healthcare at all. So this is where I think having that telehealth is extremely amplifying efficiency. But even in places that has access to healthcare, is now you can actually using these sort of telehealth. Essentially, is really I think that telehealth is like a resource matching system, right? A pool of patient, a pool of provider, specialists, how to match them in the most efficient way at the grand country level. I think this is extremely, extremely exciting.
Good, very good. Well, we have reached the end of our webinar. I would like to give a great thank you for all of you, of all speakers, Milton, Sean, Vargas, Rayleigh, for sharing the experience, the strategies, the visions of their successful organizations. So it was very important information that we've got here today. More are to come in the next webinars and the next activities from the International Society. I thank you very much for Michele as well for being with us. And in backstage, Frederick Livins, that is supporting all of what we're doing here, not only here, but also in the International Society. This webinar will be available in the next few days, and also in the next few weeks, we'll launch the new website of the International Society. So again, I leave you with the invitation to join the International Society and to follow us in the website and other social networks to be aware of what we are doing. Thank you very much again, and have a nice day.
Thank you, everyone.
Thank you.